Hey everyone, welcome back to the afternoon session of House Healthcare. And we're keeping with the theme of the Occupational Therapy Compact. And we have Lauren, I always say Lyman, but it's Lehman, right?
Yeah.
Lehman. Okay, thank you for that. General Counsel of the Office of Professional Regulation. And we also have Lauren Hebert here as well, who is the Deputy Commissioner of Deputy Secretary of State. Thank you. I got to get back in the groove of remembering everyone's titles. So anyway, Lauren, we're going to turn it over to you.
Right. Thank you. Lauren Lehman, OPR, General Counsel for the record. Thank you for allowing me to testify remotely. I am in the last 2 days of my Christmas COVID isolation.
Oh, sorry. But we're glad you're there and you look healthy, so that's
and I'll be in there on Friday. And Lauren has been gracious enough to hop across the street to be there in person if you have any questions or want to discuss this in person. We're all familiar with it. So, and speaking of familiar, you all received some great testimony this morning about the Occupational Therapy Licensure Compact. So I won't bore you with any background unless you want those additional details. I did hear there were questions about current licensing of occupational therapists and occupational therapy assistants in Vermont. So I'll address those questions as well. And I'll probably start with that. So right now, what Vermont statute says is the educational qualifications of licensure are based, you just have to graduate with a bachelor's degree or higher from an ACOTE accredited school. An ACOTE is the Occupational Therapy Accreditation Organization. So they have an accreditation program for OT programs throughout the country. The sole requirement in Vermont is you graduate with a bachelor's degree or higher from an accredited program. And the same for an associate's degree that for the OTAs is that it be a ACOTE accredited program, associate's degree or higher in OT.
Okay, so I just want to stop there. Thank you, Lauren. Did that answer everyone's question?
So there's no grandfathering of a bachelor's?
I think the grandfathering in the bachelor's language has to do with, because we defer to an ACOTE program, if they start only accrediting master's degree programs or only accrediting PhD programs, doctoral degree programs, they grandfather in those people who graduated from an accredited program 20 years ago that was bachelor's degree. So that's the grandfathering language. The way this compact works in terms of qualifications for licensure defers completely to the states. Just says you need to have a home state license. And I think that reflects kind of the changing nature of OT education over the last 30 years and how varied states are and the levels they require. So it's a pretty open door right now. And Vermont has that bachelor's or higher as long as you're ACOTE accredited.
Great, thank you.
So you've been through the basics of this compact. It's like all the other ones you looked at last year, or 3 of the 4 you looked at last year with a privileged model. Folks need to get a home state license where they reside, and then they go to a compact commission, say, I would like to have a privilege to practice in Maine, New Hampshire, and Vermont, and they pay a fee to the compact commission for that privilege, and then they pay a state specific fee as well. So that, and then they get the compact commission will notify Vermont, hey, Joe Smith, home state Massachusetts, is coming to practice under a privilege in your state. So that's the very basic model here. As always, the benefit of that is mobility for licensees. There's some shared disciplinary information, which goes a little bit toward protecting the public. And so it is good policy, and OPR strongly supports that good policy. Also similar to the other compacts, it does mean a revenue loss for OPR, most likely. When we ran the numbers yesterday, just looking at, the current member states, so those 28 member states who we have licensed in Vermont, from those member states, the minimum impact, if those folks no longer have to pay for the license here, is about $28,000.
28?
28 biennial, so every 2 years.
Okay.
If more states join the compact, that could be up to about $39,000. Those every 2 years. Over time, that's a significant impact given the structure of how OPR is funded, how programs are supposed to support themselves and regulation. It's offset somewhat by a state-specific fee that we can charge, and that's all TBD. As Lindsay mentioned this morning, the privileges are not being issued yet. There's no established rate for the compact fee for the licensee, and Vermont has obviously not yet set a state-specific fee for the licensee. There's also additional costs such as building the application system into our IT, which is about $10,000. And there'll be an annual fee we have to pay to the compact, which has not been set yet, but will be set by October 1st every year. So those are kind of the things that OPR weighs. We strongly support the policy here. It's good for mobility. It's good for public protection. We have no problem with the content of the policy. Our concerns lay mainly in the costs and how we offset those costs while still protecting the public and doing what we're required to do and love to do. So.
Great. All right, questions, Art, and then Brian, did you have a question?
Yes, Lauren, thank you. I just want to make sure I understand the fees. So a person must buy a home state license, must buy a compact, if you want to work in the states, like say you want to work in New Hampshire and Maine. Okay, so I need to buy a compact license. And then I need to also buy there's a separate fee for each of those two states? Is that what I'm hearing?
Yes, close to that. It is, so you buy a home state license.
Yeah.
And then once you have that home state license, you're eligible to get a privilege to practice in any of the member states. So you would go to the Compact Commission, which is the centralized compact regulator, and say, okay, I want privileges to practice in another state, just say New Hampshire. And they would say, okay, you owe us a fee, a basic fee for the PT compact. I think it's $45. And then there's a state specific fee in addition to that. So New Hampshire might say, well, we charge $75 per privilege. So the licensee would pay the home state fee for their home state license, then pay that commission compact fee of $45 and the New Hampshire privilege fee of $75. If they wanted another state, they may have to pay another state specific fee, but they wouldn't have to pay an additional compact fee.
How does all that compare with me just trying to get a New Hampshire license and forget the compact?
Usually it's, so there's a couple additional fees. If you were to go through having to get a New Hampshire license, you would have to pay the full home state fee in that state. So if you look at the compact fee, the state specific compact fee, they're often a portion of what a full license would cost.
Okay, so a person can save money and probably time by going through the compact?
Significant amount of time. There's also continuing residency and continuing education requirements for each license you hold. So, say New Hampshire requires 40 hours every 2 years of continuing education and Vermont requires 20. That person would have to maintain both licenses, would have to do the full 40 every 2 years. Whereas if they have the compact license in their home state's Vermont, they'd only have to do the Vermont CE and wouldn't have to go and get the continuing competency in New Hampshire as well. So they'd save that cost.
Okay, so this does save the OT, the person, money and time.
Definitely. And it also, we were talking a little bit about educational standards. If somebody is eligible, say at a bachelor's level in one state and another state has a master's level requirement, they may never be able to get a license in that master's level state. The way this compact works is they would be eligible for a license in that state and to practice in that state.
Now, is this an every other year fee or every year, or how are these fees recurring?
They occur based on the home state's licensing schedule. So for us, it would be biennially, every 2 years.
Every 2 years, so they would get it every 2 years, and also the compact licensure every 2 years too?
Yes,
The
it would-
privilege?
Yes.
Okay, all right, okay, thank you.
Alyssa, and then, I'm sorry, Brian. Alyssa, and then Leslie.
It's similar to Art's question, but but I'm hoping you could give us a little more detail for the record. Because Art's questions, they were mostly about fees, which are like a financial barrier to getting licensure in different states. But I'm wondering if you could identify any other barriers. I heard time may be mentioned in the last question, around the questions, but there are others. And so I'm just curious if you could identify, like, what are some of the other barriers right now for interstate licensure besides fees and besides the time people have to put in? For example, like getting your transcript or, some other things or tests or et cetera. Because I think it'd be good for the record just to be able to compare the amount. So when we think about cost, it's more than fees. So like if we could just compare what the current cost is versus what the cost will be when we're in a compact. And then I have a second question, but I'll wait.
Yeah. I appreciate that because then I'll remember.
Yeah.
Thank you. Yeah, there's intangible costs as well. There's ordering your transcripts, there's ordering your test scores. Those all have to be typically, if you're applying directly to the state, primary source, meaning you can't send them. They have to be ordered from the school. They need to be ordered from the testing institution and submitted to the state. All of that can take time, which is not intangible when you're moving and you need to be able to practice. Sometimes you need to then be able to be credentialed by an insurance agency. So the timeline kind of compounds on itself. Insurance provider, not insurance agency. So all of that time can be really stressful. It can delay beginnings of jobs and, just the administrative costs on the state level of reviewing an entire application, making sure that everything's correct, doing any verifications of licensure. So if you've been licensed in another state, OPR will reach out to that other state to ensure that your license is in good standing. That can take a very long time when you're dealing with some of the larger states. And so all of those can be additional costs. There are additional costs that OPR would need to implement just like with other compacts. For this compact, this is a little off topic, but we would need to start doing a background check for OTs and OTAs who want to participate in the compact. We don't currently do that background check. So that would be an additional requirement for those folks who want to participate in the compact. They'd have to purchase that background check and go through that process. So I think the benefits still outweigh the costs for licensees, and they can always choose to do that. Again, a compact license is always elective. Folks can decide, I have no need for an OT compact license in other states. I just want to practice in Vermont. They can get a home state license in Vermont, and the process wouldn't change for them.
Second question.
We've been using a term called grandfather to describe if somebody is currently receiving sort of some kind of benefit that it will continue even things change. Is there a reason why we don't say grandmother?
I was wondering when you were going to come. I knew that was coming.
Lauren didn't start with that comment, so.
Grand grown up, you're grown up is what we're supposed to say, right?
Ancestor, how about ancestor?
Ancestor.
All right, Alyssa?
No, I just wondered what the current fee is for a 2-year license for OT.
Good question. I'm going to have to look that up and get back to you.
And
Lauren Hibbert might know.
And I'm just wondering about the administrative burden on OPR. I mean, because there are still things that you need to do if somebody wants to choose Vermont as a member state.
Yeah.
What do you think the administrative burden between a full licensure and a compact approval licensure as a member state? What do you think the comparison for the amount of work that you would have to do?
It would not be significantly reduced. There'd additionally be, I think there'd be some reduction long-term. Initially, what we have to do is set up pretty much a separate license space for folks who want to pursue the compact license because of that background check requirement and because of just the capacity of Vermont's background check. We don't feel at this time that we want to make everybody get a background check because we've encountered some bottlenecks in that system, and it's really been a barrier to the workforce. So at this time, we think that only those seeking the compact licenses should be pursuing the background check, which means we need a separate licensing pathway for them, which means that we're pretty much running a separate licensing program for them. That initial startup cost is not insignificant. I think once we have it built, our system is so nimble that it's even with any license, we're pretty good at getting things done within 1 to 3 days. We won't have any review of education. In this program, in this profession, we don't have to do a lot of that anyway. So I think it would be pretty comparable for the long term.
And my other question was, due to our proximity, of course, to New Hampshire and Dartmouth Hitchcock, I'm wondering, have we done an analysis? And since New Hampshire is already in the compact, I think they were on the dark blue. I'm wondering, how many licensed OTs in the state of Vermont actually reside or are affiliated with New Hampshire providers? And are we anticipating losing all that revenue?
We currently have, yes, we are anticipating that we would lose that. We currently have 53 OTs and 18 OTAs. Thank you to Dylan Bruce, our policy analyst, pulled these numbers together yesterday. So currently we would lose 53 licensees at a renewal fee of $180. And we'd lose 18 OTAs for that same renewal fee of $180.
And 180 is what, every 2 years?
180 is every 2 years.
Biannual. Okay.
Thank you. Leslie?
Hi, thanks, Lauren.
Oh, yeah, you're over there.
So I'm just wondering how this compact differs in any material way from others that we've looked at. Is there anything special that stands out to think about?
No, actually, I think this one's pretty comparable to the PTs and the PTAs that you all looked at last session. I think the biggest distinction is just that, the education component, but other than that, it's very consistent with what you looked at last session.
Thank you.
Daisy?
I'm thinking about workforce issues and practitioners and just sort of access to participating in the compact. I remember the requirements included having a social security number or a national practitioner's ID number. Can you tell us a little bit about what it takes to meet the requirements for a national practitioner's ID number?
I don't have that information off the top of my head, Representative Rebecca. I can look into that and get back to you on that.
Okay, the reason, also, I guess, just to inform the committee, I know that Lori shared information about Vermont having access to J-1 visas for foreign-born providers. I'm just thinking about the importance of individuals who need OT having a provider who looks like them, is culturally aware of their experience, and just thinking about having improved access to diversity in this field and whether the J-1 visa providers could potentially have access to this.
So I see some head shaking, so we're going to wait till the OTs come and testify, and maybe they'll comment on that.
Great.
And then Lauren, if there's anything you want to follow up with, that would be great. Right?
I have it's like a clarification question for
Sure.
Daisy. Are you talking about MPI numbers?
Yes.
Because I think it's actually, isn't it National Provider Index or something? Doesn't that? It is practitioner identification? Okay. Yeah, I know what an MPI number is, though. I just didn't know if that's what you were talking.
I love having clinicians in the.
I know, it's great, isn't it? Lauren, I have a question. What is, and this may be in your written testimony, so I apologize. What is the recommended, I can't think of the word, the date this should all start? Effective date, thank you.
Effective date. I need to talk with our staff a little bit more about this, but we have the other 3 coming online in July 2024. I would say the earliest would be January 2025, maybe July 2025. I just need to, I think we need at least a year to get it set up, so.
Okay, all right, if you can just let us know, like Tuesday, that's.
Yeah, oh yeah.
Okay,
I'll
that'd be
ask
great.
right after. Thanks.
Okay, wonderful. Any other questions for Lauren?
Just, when you, so the PT compact, that hasn't gone into effect yet?
That goes into effect on July 1st, 2024, so this summer.
Okay, because I thought I heard that PT compact did not affect workforce. I thought early this morning, I heard that said. So I'm wondering.
Well, there's other, I think that was in reference to other states.
Okay.
Yes.
And that's what I was gonna ask. And you may not know this, and probably future witnesses here will talk about it. Is there any hesitancy of folks on our border, especially with New Hampshire, about losing business because of something like this? Has been any rumblings of that from the actual occupational therapists themselves, or is everybody very positive about it? You may not know.
I've only heard positive at this point. I don't know. I think Lindsay was here speaking for the association this morning. She may be more attuned to what's going on in the field, but our advisors, I think one of our advisors is scheduled to invited to testify later today. So generally supportive.
Yeah, thanks.
Great. Thank you, Lauren. We hope you feel better. See you soon.
Well, see you Friday.
Great. All right. We have Representative Mary Catherine Stone back to start. We'll have 1, 2, 3, 4, 5 occupational therapists with us. One is scheduled to be on Zoom at 2, so we'll just watch the clock and make sure we accommodate that. Welcome back.
Thank you. Good afternoon. I am Mary Catherine Stone, and I'm a representative for Chittenden 14, as I said earlier today, but I'm also an occupational therapist practicing here in Vermont at UVM Medical Center. And my testimony is going to be accessible through your documents on your House Committee on Healthcare page.
Great.
Thank you for allowing me to come back, provide testimony on H247, an act relating to Vermont's adoption of the OT licensure compact. I come to you today as a legislator, a proud representative of Chittenden 14 in Burlington, but I also come to you today as someone who trades in my power suits for a pair of scrubs when I'm not walking the halls of the State House. I am an occupational therapist, and a proud one at that. I've worked in the field for over a decade, and I currently practice at UVM Medical Center. A lot of you may think that being an OT means that I help people find jobs. Actually, that could technically fall in the scope of my profession. However, I want to take this opportunity to educate you on what occupational therapists can do and why they play such a vital role in our healthcare system. Occupational therapists help people of all ages, womb to tomb, as I like to say, meaningfully participate in life activities, also known as occupations. That means we tailor our interventions to help people engage in activities that they want and or need to do, including taking care of themselves, their families, working, volunteering, going to school, among many others. We provide recommendations for things including but not limited to adaptive equipment, home safety and accessibility, caregiver and family training, cognitive tools for memory and executive functioning, and returning to work, school, and leisure activities. And the list goes on and on and on. Due to the expansive scope of our profession, we work in a variety of settings, including home health, schools, skilled nursing facilities, inpatient acute care, rehabilitation hospitals, and outpatient clinics. And again, that list can go on and on and on. I'm asking you for your thoughtful consideration and support of this bill as it affords more OTs greater access to practice in this wonderful state of Vermont. I will tell you, as an occupational therapist who currently holds licensure and practices in this state, we need more of us. As the majority of our state's population reaches older age and patient caseloads grow more complex, occupational therapists are needed to address the issues that are seen at the bedside as well as to prevent rehospitalization. There are currently 28 states who have enacted compact legislation. That's more than half of the licensing jurisdiction of our country. If enacted, this compact will allow OTs and their assistants the opportunity to practice in states that have joined the compact without having to secure a new full traditional license in each state. Said traditional process often equates to duplicative work and long wait times that create unnecessary and costly barriers for clinicians to practice. I'm going to go off my testimony now and just tell you, when I moved here in 2016, because I wanted to be in Vermont, I started the process for licensure. I was in DC, which is one of, as you can imagine, practicing in the nation's capital, where I was at Children's National, literally opening myself up to potentially treating the president's children. That license to practice there is extremely thorough to get licensure there. Yet it took me months to get my licensure set up in the state of Vermont.
After having the one in DC.
Right, after having the one in DC. So lived experience, it is costly and it is unnecessarily laborious to get a licensure here. The OT Compact before you helps break down those barriers. It preserves the regulatory authority of each compact member state to protect public health and safety through the state's existing regulatory structure. Therefore, our state's unique scope of practice will be honored. Additionally, this is not anticipated to yield substantial additional cost. Yes, there may be a cost for additional software to connect to the compact data system, as well as cost associated with the attendance of Vermont's chosen commissioner to the annual in-person OT Compact Commission meeting. However, there is no financial beneficiary of the licensure compact, and it is not intended to generate profits. It is anticipated that any fees collected via setting an appropriate fee for the compact privilege will offset those administrative costs. This was the first bill I sponsored. I spoke with legislative counsel only a few weeks after I was elected, before I even stepped foot into the State House. I then hit the ground as soon as I was sworn in, and I collected the large number of signatures that you see on the list of co-sponsors. Plenty of veteran legislators assured me that I did not have to keep running around with my pen and clipboard getting signatures, but I kept going. I didn't stop because it's important to share just how special and needed my profession is. I am proud to be an occupational therapist, and I know firsthand that we should be making it easier, not harder, to allow others to practice this wonderful profession in this state we call home. Therefore, I ask you to strongly consider passing this bill.
Thank you.
Thank you.
Questions, Leslie?
So totally yes, there. But what I'm curious about is telemedicine, because I'm picturing, state to state. And OT I see is a very hands-on kind of profession. So how does it work in a telemedicine direction?
Yeah. One fun thing that I remembered, NPR did a story about occupational therapists in 2017, and they said that we are one of the few professions who cannot be overtaken by robots. But, yes, I know, job security. But during the pandemic, that really put it to the test about how are we going to practice when we're not hands-on? And we can't. Now, I'm not doing it because I work with people who have spinal cord injury and traumatic brain injury and acute inpatient rehab right when they're fresh out of the gate from an injury, an illness, a disease, et cetera. But a lot of people are doing it in outpatient settings in particular. We have a really dynamic and awesome clinic at University of Vermont Medical Center that works with people who have Parkinson's. That's something that you can do through telemedicine, and you can give people home exercise programs, you can do caregiver training, all of that stuff remotely without having to be hands-on. Mm-hmm. So we are with the times, us OTs, and we figured out how to do things via telemedicine.
Mm-hmm. Thank you.
Mary,
Or Alan?
it's okay.
Sorry.
It's not. Okay, so you're happy with your job and everything. So what's the benefit of this enacted bill for you?
For me, well, when I left on Friday, because I worked until the very end before I came here, I had scrubs on up until 4:30 p.m. on Friday. When I left the hospital, I left a huge caseload behind, and we don't have near enough OTs to take on that work. And we have new grads who come and they interview after they graduate from different programs around the Northeast, and they want to work at University of Vermont Medical Center. But what worries me is if it's easier for them to practice in a state like New Hampshire, they're going to go there because they can get paid and pay off those student loans more quickly than waiting for months like I did to get a paycheck. So I think it'll really
So it's going to
help bring people in. It'll help the patients. It'll help me feel less guilty when I go to the state house and I leave that caseload behind. Yeah.
What triggers your, and OT's involved, not yours, but a therapist involvement with the patient? Is it referred from a doctor? Is that what triggers it? Just wondering.
Yes.
Okay, so
Yes.
they get referred to you folks by a doctor or of some kind. Okay, it sounds almost like you deal with some of the, and trust me, I'm just trying to understand what you do. It almost, I'm sure you probably do, but when you say getting someone back in school or into work, this is all due to a physical ailment that the person has, or is it other things?
It could be a physical ailment. It could be because of a brain injury where their issues are not so much a physical impairment, but maybe cognitive,
Okay.
So no, it's not just because you broke your arm and, you can't return to school because you can't.
But it's not because someone just doesn't want to go and now you've got to counsel them into going? It isn't that, is it?
That's where our name gets confusing, right? That's why I said you think we're the ones who help people find jobs, but no. It could be part of our scope of practice. If you can't return to your job because you had a stroke, or you can't return to your
Correct.
job.
That's a
yeah.
physical thing I see it as. Okay. All
But we
right.
work with behavioral health, with mental health as well.
You do? Mm-hmm. Okay.
Sure
It doesn't
do.
require some sort of a separate thing to work with those type things, or?
No, we have extensive training in school, so we learn how to work with actually, OT has its roots in mental health. Back in World War I, when soldiers came back and they were having difficulty returning to the workforce for whatever reason, maybe it was because of what we now call PTSD, or maybe it was because they had an amputation, et cetera. OT, that's how we came into existence. We were the people that said, we got to get these soldiers back into the workforce, back to their homes, back with their families. How are we going to do it? And therefore, our occupation was born.
Okay, so it's a combination of physical and mental issues.
You're right. Yep.
That trigger you going in, and I assume that's the difference between you folks and just a physical therapist.
That's right. There's always a joke, and no, hate or shade to physical therapists. We love them. We work with them, but physical therapists are the ones that will help you like walk into the kitchen, walk into the bathroom. The OTs are the ones that are like, okay, you're in there. Now what are you going to do? We're the ones to help you figure that part out. Right.
Okay. All right. Okay. Thank you.
We have a couple more questions and then we'll move on. Brian?
So I'm thinking about telemedicine, and then your comment about, somebody's gonna go to New Hampshire instead.
I'm struggling to see how this helps entice people to practice here, because once they're here and they reside here, their home state, they then have to go through the full licensure process anyways in the home state. Am I missing something as far as, and we talk about this with like military spouses as well. But I believe that if you reside, where you primarily reside is where you then have to be fully licensed in that home state.
I think
Am I missing something?
Jennifer Harvey, Legislative Council. I think that's right. Where you're residing is your home state and you need a full license there. There's sort of the nuance for the military spouse.
So the compact really doesn't help entice people to come to Vermont. It's more
Retention.
OTs in other states being able to provide telemedicine to Vermonters.
That's what I'm
So to clarify a little bit though, I think there was that kind of streamlined using your compact privilege to verify that information to go from member state to member state as your home state.
Okay, so it's easier.
Process up.
Okay.
We have your background check, we know that you went to school, we know that you passed your boards, yada, 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 instead of me where I was like, okay, let me like cough up the money to contact University of Alabama Birmingham to dig up my transcripts and knock the dust off, you know, and then ship it up here. Like, you don't have to go through all of that.
Okay.
It makes it easier.
And that's clear. I mean, maybe it's more of a question for Lauren, but definitely that it's not like the process would start from the very beginning.
Right.
Okay.
Yeah.
Okay, thank you.
Right, and then Mari, and then we'll go to Hannah.
Yeah, I have a question that was separate, but what we were just talking about, I think I wanted to ask about that and then ask my question. My question has more to do with what the questions were before, but would it be beneficial to occupational therapists who want to practice across the borders of adjacent states? I think I see that as like a possible benefit here. For example, if you live in New Hampshire and that's where your license is, you don't have to get the license in Vermont, and you can work either in New Hampshire or Vermont. You could have two jobs. You could work for a company like Dartmouth that works across state lines. I mean, are those kind of part of the reason?
Yeah.
Okay. So back to the questions before, where we were hearing, we were talking about how occupational therapy addresses not only a person's physical functioning, but also emotional, mental, cognitive functioning. Can you say a little bit more about the occupational therapist's perspective on how mental and emotional health is physical, how your profession might be influenced by neuroscience, for example, and when treating traumatic brain injuries? Can you maybe give a little more detail about like what an intervention could look like for people, just to help, for the record,
For us to understand.
Yeah, and not just us, but the public, so people better understand sort of like when you're treating traumatic brain injury, how are you thinking about it? How is a mental health issue actually physical because of neurons, et cetera? Because I believe you do look at neuroscience and what you do.
Yep.
Yeah, so maybe you could say a little more.
We do. So this is what led me to the field is, you know, I had a background in art. And so when I decided that I wanted to work with patients, I looked at all kinds of different professions, and occupational therapists tend to be like most creative in my opinion. And it's because it really is a holistic field, and we look at the patient as a whole, like mind, body, spirit, and recognizing that all of those are interconnected. So I'll say like a patient with a traumatic brain injury, they may have physical impairments. They may like have horrible balance. They may have vestibular issues that cause them to be super dizzy or have visual impairments, but they also may have anxiety, coping issues with their illness as they move through those stages of healing. They may have cognitive impairments where their memory is impaired, their executive functioning is impaired. And if you don't like look at the whole person and treat all of those things, then they're not going to be able to meaningfully engage in things that they want or need to do, whether it be brushing their teeth or taking care of their kids. So you have to go in and just be like a jack of all trades and say, okay, not only am I looking at their balance when they get out of bed, but are they able to see the world around them? Are they anxious to even like initiate working with me? Are they able to even remember who I am? Is that maybe why they're anxious? Because their memory is impaired and they can't remember me, even though I met them 2 hours ago. So, yeah, does that help?
I think so, and I think the thing I would highlight that maybe then you'll speak more about is that a person having anxiety is actually, that anxiety is represented physically in the brain by connections between neurons, and that those connections also interconnect with other kinds of neurons. Like your motor cortex is wired to your limbic system, and that's wired to your frontal cortex. And like when you're designing treatments, I guess I'm curious about how you think about, how you're exercising the different parts of the brain together.
Well, so I think what I'm going to do, if it's all right, is save that question for some of the others who are here to
That's fine,
testify,
yeah.
if you don't mind. And just to give everyone a chance. So, but Mari did have a question, and then we'll go to Hannah.
More of an additive comment to what Representative Black is bringing up about how is it going to help if people just move to Vermont and then get a Vermont license? And to your question about how is it going to help? There are, like, just like there are traveling nurse agencies, there are occupational therapy agencies that help clinicians do like what I have done is work short-term in other states that are compact states. So Vermont can get help temporarily.
When she's in legislature.
When she's in the legislature, yeah. It's possible that traveling occupational therapist or assistant could help.
Thank you.
Thank you very much. We appreciate it. Now we have Hannah Bloom, who's the owner of Play and Bloom Therapy and who has been with us almost the whole morning. So
Help calm my neurons so that I was ready to be able to.
so glad you could join us. Thank you, Lauren. If you can just introduce yourself for the record and then start.
Hannah Bloom, therapist, having me. You have my testimony in writing should you want to read along. Format-wise, is it okay if I go off testimony and have thoughts that come up? Okay.
Yep.
So good afternoon. I am Hannah Bloom. I'm the owner and solo practitioner of a very small little business called Play and Bloom Therapy. I'm a neuro-inclusive pediatric occupational therapist. And I'm Vermont licensed and nationally registered through the board certification. I've been practicing for 14 years. The first 10 years were in New Mexico, and then the last 4 here in Vermont. I'm testifying in support of the House Bill 247 to adopt the Occupational Therapy Licensure Compact, the OT Compact in the state of Vermont. As an OT, I've been actively involved with the American Occupational Therapy Association, which is our national association responsible for representing the interests and concerns of occupational therapy practitioners and students. As well, I've been involved with the National Board for Certification of Occupational Therapy Incorporated, which develops, administers, and continually reviews the certification process based on current and valid standards that provide reliable indicators of competence of the OT practice. Both of these organizations have collaborated in drafting and supporting an interstate compact for OT practitioners. Both organizations hold the public interest as well as standards of best practice for OT practitioners as their missions. And I've been a member and am currently hold a seat on the board of the Vermont Occupational Therapy Association. And while in New Mexico, I was an active member of the New Mexico State Association. I have 2 personal stories to share with you today that will highlight the impact of the OT Compact will have for families and practitioners in Vermont. And then we can review the bullet points again, but I feel like we've gone over them a bunch, so we can skip that part. And then questions and thoughts and concerns. So the first story is about my journey as a therapist. And from conversations and shared connections with other OTs, I can say that this is a common thread. It's a common story. Many OTs share this as why they continue to be occupational therapists and love it. So as a pediatric therapist, I have an amazing opportunity to create therapeutic relationships with families that can last over years of development. Some families I work with, I've known since their child's birth and the child's long, harrowing stay in the neonatal intensive care unit. And I still know them today, 15 years later. While in New Mexico, I was a part of a community of families and advocates for disability rights. And then my clinical work was directly with clients and families. When my own family here in Vermont moved into a stage of life that required me to return, I decided to move away from those connections and consequently lost some of the access to be a part of that core team for the families and their children as they grew and changed and as their children's needs changed. And now at times, teenagers changed, the changes have come into more adversity. Multiple families in that community have reached out asking if I would continue to be an active part of the teams. For many reasons, I've held on to that, and I continue to be present and active. The OT Compact proposed would allow me to continue to work in a clinical role without the burden of maintaining 2 state licensures or transferring the burden of payment onto the family in need, which means As a licensed therapist, if my license is not in the state where the client is, I cannot bill the insurance of the client for payment. So families can pay out of pocket for my service, telehealth, but it requires them to then hold the burden of that payment. I can't bill their insurance. So then the second anecdote is my own search for a feeding specialist, either an OT or speech pathologist, during my second child's infancy. One child was born here and one child was born in New Mexico. And that's a whole nother story of just the experience of postpartum in the two different states. With this story, with this child, we struggled with feeding difficulties from day one. And through the haze of postpartum, I pushed and I searched for a clinician who could guide me to help decrease the pain and increase the function of feeding for my baby. Had we been able to use the compact and search across state lines, there's the possibility I could have found a specialist who took insurance at a faster rate. Most clinicians here have at least a 3-month wait list, which is a long time when you are doing feeding with an infant. I needed immediate assistance for our quality of life and the development of functional feeding patterns for my newborn. The proposed legislation would change both of these stories by allowing the practice of occupational services to be rendered in the remote state under the laws and the rules of the home state for the practitioner. And then the back page is all a continuation of the formalities that I think we have covered.
Thank you.
We can move on to questions.
Sharing your stories. Alyssa was first, sorry, and then Art.
I'm glad you brought it up because in the back of my head, because I always think about billing. I can't get away from it. So I'm assuming that occupational therapists bill under their own name. They don't bill incident to or under the supervision of a supervising physician or anything like that, correct?
Dependent on your workplace. So as a PLC in the state of Vermont, and I have an NPI number, I bill directly. I'm credentialed with multiple insurance carriers. So I bill directly to the insurance company. Should I work for the university, it goes into the university's billing system, but it is reimbursed directly via the OT CPT codes.
Okay.
Blanking on what CPT.
And is the rendering provider the OT or is it a supervising provider?
OT.
So I'm assuming an OT assistant would be billing under the supervision of an OT.
Correct.
So I'm thinking about if you're in a different state and you have a compact license, say as an OT assistant.
Correct.
But the supervising physician that you work underneath does not have a license in that state, then you would not be able to actually bill for services, or am I correct?
If you're, let me just make sure I have the scenario correct. You're an occupational therapy assistant and your home state is Vermont, but you're practicing in New Hampshire. Your supervisor is in Vermont. No, your supervisor would be in New Hampshire. It bills through where the provider is. So where the occupational therapist, who is the practitioner,
But what if
would be
the
submitting.
supervisor does not have a compact license?
Oh.
And that assistant would not be able to use their other member state license.
Yeah.
I can speak to that a little bit.
Okay, so first off, you have to say your name.
So Emile Parmalee, occupational therapist. So to work as an assistant, you have to be under the direct supervision of an OT, depending upon how long you've been in practice. It may be less, it's similar to nurse practitioners. When they first start, they have a lot of oversight from physicians. As after 40 years of being a nurse practitioner, maybe they have less oversight. It's the same for OT assistants in most states. They have to have a supervising OT that is licensed in that state. So say we had a Vermont home state OTA that wanted to work at Dartmouth, they would fall under the supervision of a licensed OT there. Quotas are typically not hired without, they are either working with an OT to provide them supervision, but primarily the employer is providing the supervision. So OTAs typically wouldn't be in private practice, a standalone private practice. Does that answer your question?
And I don't think we have any insurances coming in. Is there concern about like?
Lauren keeps
people-
popping up,
Oh,
so Laura.
concern about people who are, have a compact license to practice in the state. They're not, it's not the home state, Vermont's not the home state.
Right.
Are insurance companies actually credentialing these providers to be able to do that? Or have they just sort of washed their hands of it and?
Lauren Lehman, OPR General Counsel, for the record. Thank you. I don't know exactly for insurance purposes, but I can say that in the compact language, there's a special provision regarding supervision for OTAs, which says that the OTA must be supervised by an OT who is either licensed in the state where the practice occurs or has a compact license there. And my guess is that that legal authority would facilitate coverage.
I'll answer that question. Thank
Great,
you.
thank you. Art,
Yeah, so now I'm trying to.
remember what it was?
Yeah, I think I have it. What guides, what can be, your examples triggered in my thought that this stuff would be done via telehealth. But can all occupational therapy be done by telehealth, or are there some things that can and can't? And is there lists of those things?
There are guideline practices for telehealth from the American Occupational Therapy Association. I don't think it gets into specifics of yes or no. I think it becomes much more about treatment development as the therapist and in collaboration with the family and the teams. There are pieces of OT practice in my practice as the therapist that I do that are very accessible via telehealth, and there are pieces that require me being hands-on, me being with the families and with the client. As for the feeding piece, as the client looking for, as the mom looking for the therapist, yeah, exactly. I could do that on telehealth because I would trust somebody to guide me what to do for exercises for my baby. But it's just a little bit like, they would be guiding a therapist who kind of knows what they're feeling for and what they're doing. I don't know that I would trust feeding therapist as a whole to be just telehealth, but that's really clinician, it's up to clinical judgment. And then it gets into kind of like writing treatment plan, what your long-term goals are, and into really specifics about what.
Yeah, I'm trying to visualize that happening over telephone.
Well, this is video. This is a video.
Okay.
Yeah. So if I were to be with my babe and I had a therapist on a video call with me, and the therapist had a doll or had a mouth or had some sort of model, I would be able to take direction of these are the exercises to do, try them with your child. They would watch as I was doing them. They would have analysis. They'd ask me questions. It'd be very dynamic.
All right. And I understand all that, but I'm wondering who makes the call if that's good enough to be considered therapy. I maybe Lauren might know.
Yeah.
I don't know, but I would assume
Looking
there's
at
a
the screen
standard
like she can see me.
everywhere that would address that.
Yes, there are.
Because we've talked in this committee about, what if you just had a telephone? What if you didn't have video? What happens then with this, or does it happen? And so I just posed a question.
Yeah, Hannah, didn't you say that there's guidelines?
There are guidelines from the American Association, from the National Certifications.
And I would assume the compact has that as part of something they have, maybe?
I think it's under licensure. It's under our code of ethics. It's under, it's within the profession of practice, yeah.
It's something that's cared for. I would think the insurer would be very interested in that.
And that's the other thing, the balance is within, in order to be reimbursed, I need to be proving efficacy and they need to be seeing benefits. Otherwise, I am not reimbursed as the provider. So it falls on me as the practitioner.
Okay, thank you.
Lauren, did you have anything to add?
Sorry, I had to get to my unmute. I don't have anything to add. Unprofessional conduct is incorporated into the compact. In Vermont, it's unprofessional conduct to practice in a manner that is incompetent, and we assess that based on recommendations from associations.
Great. Any other questions for Hannah? Thank you.
Do you want me to answer your question about neurons?
I want whoever's comfortable to stay.
Are you comfortable answering?
Yeah, I mean, a huge part of my practice is based on this. Actually, came up with the questions regarding kind of, is there a place for an OT when someone has the outward perception of not wanting to find the job, right? That kind of like typical this is. So yes, absolutely. If the not wanting is based in some neurological impairment or neurodivergence that is creating barriers within access. And so I absolutely are the way that, I mean, I'm reading your guiding principles, like so much of this exactly speaks to what we are as a profession, how we work to see access to occupation, meaningful occupation, access to meaningful occupation, and access to self-determination and self-actualization. All of those pieces very much lie in, does your neurology match your environment? And if there's a change in the environment that can be done so that it is a better environment for your neurology, awesome. If there's something that is specifically acutely in your neurology that can be, habit changed or prosthetic based, good, change the system to be able to then access the environment. But OT looks, in many ways, looks at this big, huge, zoomed out, holistic picture of it is about humans, us, being able to be the most true selves we can. And so where in that system is it neurology? Which, yes, absolutely, it starts with the cortex, but your nerves go everywhere. So we are all connected into that piece of this is a presentation of our neurology. Or is it based in environmental access? And are we missing something in the big picture of how we provide access to healthy living and systems?
I appreciate that because I think the more you speak about the details of your profession this way, the more of a record we create and the more justice we're doing to the work you do. So that's why when you said, do you want me to say more? I was like, yes, and if each of you want to speak more to that, because I think it's also something about your profession that stands out is that similar to social workers, you're looking at a person in their environment and you're looking at the person as a whole and not saying that like any choice or behavior is separate from the physical, because every choice and behavior we make there's neurological record of that. There's pathways that are firing and they can be exercised and trained and grow. And I think you just spoke to that, so I appreciate it.
Yeah. I will say what's fascinating about being in this committee to me is how much we learn about the professionals that are in the healthcare system.
Yeah.
Right? I mean, it's just fascinating sometimes to learn what you all do. So,
Could I comment on that too? When I hear occupational therapy, I think of occupation only, but it isn't that, is it?
No.
It's almost a misnomer to call it occupational therapy.
Right. It's yes.
And so, yeah, it's, I learned just that. I mean, it's about a lot more than that.
Yeah, the full definition of occupation, it's
your
meaningful
life.
occupation.
Yeah,
How do you
right.
occupy your days?
Correct.
And so
Your
what I'm hearing
functions.
from you though is that there's more to occupation than our paid work.
Yes,
Yeah.
absolutely.
Yeah.
Thank you all.
Thank you very much.
If I could comment?
Yeah.
Because you asked us to comment in some way that I think all of us who provide services think about their people in front of them holistically, or try to. I mean, if someone's just breaking your, sort of sewing your leg together, they have to focus on sewing your leg. And then the occupational therapist comes after because it was a team working together to get you to the next step. And this is very crucial.
Yeah.
We all try to do that.
Thank you, Leslie. So it looks like Thomas is not here yet, so we're going to keep moving on. And no, Ella's later.
Okay.
And I am going to apologize because I should have connected with the name first. Is it Emil? Emil Parmalee, come on up if you're ready. I apologize for
That's right.
not knowing that name before.
It's Gaelic, so it's Gaelic for Emily. You're not the first person even today.
Okay.
For the pronunciation, so give yourself some grace.
Thank you, I appreciate that.
So, hello, my name's Emil Parmalee. I'm actually a second generation occupational therapist. I'm registered
nationally and I'm licensed in the state of Vermont. I currently work at Gifford Medical Center in two roles, one primarily in a blueprint role. And because of our workforce challenges, I also work as a per diem OT. So yesterday I finished my blueprint job and the OT had called out sick, so I went and covered inpatient at the end of my workday. And I help cover holidays. It helps sort of keep me really embedded in a profession that I love. My primary practice areas before this were community practice. So I worked for one of the VNAs for a very long period of time. I have worked outpatient. I have worked embedded in our locked mental health facility. So I'm happy to talk about OT's role in mental health. And all of that kind of led me to sort of the idea of blueprint work and how do we reduce barriers to access in our systems for patients. Occupational therapy is an allied service that helps connect or reconnect a person with the world around them and engage in meaningful activity, either through adaptation or remediation of skills, use of adaptive equipment, family training, caregiver education training. We work across the spectrum of healthcare, but we're also embedded in mental health agencies, schools, early intervention programs, and many other community-based practice settings. Occupational therapy at its very core provides person-centered holistic care. We're cross-trained in the medical world and mental health. So a third of my training really was in developmental care, a third of my training was in medical practice, and the other third of my training actually was in mental health. I will say Vermont does not utilize OTs nearly to the extent they could in the mental health area. When I think about the many discussions that are happening at a state level right now around healthcare, mental health care, housing, childhood, education, it's hard not to recognize the need for our profession in all of these areas. I have had the advantage of being raised by an occupational therapist who, along with many of her talented and interesting friends, led me to this profession as a second occupation as an adult. In my early childhood, before we moved to Vermont, my mother actually was part of the group of practitioners in the state of Connecticut that set up their original licensure law. So I've understood from a really young age the concepts of professional diligence and the need for regulatory oversight. And I think that one of the things that makes a profession is licensure. And I feel very strongly about that. Prior to the fall of 2002, there were no occupational therapy programs in the state of Vermont. So everyone you've seen testify today, that is an OT trained somewhere else and came here. Or some of us were here, left here to get trained, and eventually came back. I trained in Maine. When I graduated, I was broke, facing a mountain of student loan debt, and the idea of trying to move back to my home state was challenging. So I started working there. My pathway to licensure was very easy. From the time I got my test results to when I got my Maine license was about 3 weeks. In 2011, I was ready to move back to Vermont and see if I was like really ready to live, around the corner from my parents again. And I got offered my first job 20 minutes into my first interview. And that was in May, early May. I immediately started my application for state licensure and never came. Multiple calls to OPR, no return calls, finally led to me taking a day off from work, calling OPR every 20 minutes until I got someone on the phone. And I thought about whether or not I was going to share this story, but I called Lindsay Thrall, who you saw earlier this morning, to touch base last night. And I said, yeah, I was thinking about the story, but I don't think I'm going to share it. She said, I had almost the same exact experience when she moved back here from Utah. And so I said, all right, I think, and I know that there are other OTs that have this same, Mary Catherine spoke about it earlier. So
finally figured out that something that I had to have sent to the state from someone else had never arrived or gotten lost in the mail and needed to be resent. So I accepted the job in early May and I started July 25th. So 2 months. And I was anxious to come back, and the VNA was anxious to have me start because they were paying a traveler for that position that I was in. So that's a pretty big expense for a nonprofit agency to shoulder. I see a lot of other, so the OT compact would have allowed me to give 3 weeks notice or 2 weeks notice at my current job, have my license in hand and start working immediately. It would have saved the VNA tens of thousands of dollars between what they paid a traveler and what they paid me. I see a lot of other benefits to this. OT, like every other medical profession, has developed specialties. So during COVID, we had licensure flexibility. So you did not have to be licensed in the state of Vermont to provide telehealth services to people that lived here. And I had many adult patients that access specialty care via telehealth that we don't offer in the state. We're a small state, we're very rural. You really have to be a general practitioner to work here because you may be seeing someone who is end-stage dementia, and then your next patient's a tendon repair. And you can't, other than there are some hand therapists, it's very hard to specialize practice in this area. So I had adult patients that would have telehealth visits with specialists for specialty evaluations out of state, and then that would inform what I would do for practice here. So that's an area, especially around autism and folks with significant sensory impairments or mental health, where that sort of opens the door for a lot of creative treatment that maybe we wouldn't have access to within our borders. So when I think about reducing barriers to healthcare, that really comes to mind. The other thing I like about a compact versus national licensure is that means Vermont gets to maintain its own licensing ability, its own regulation. We get to set our own scope of practice and maintain that within our state, as opposed to having a federal license, which that would supersede any decisions we would make as a state. I'm gonna, the rest of my testimony is really around the benefits, but, I think talking about what our profession does in mental health, or if people have specific questions, I guess I'll open to that now.
Thank you.
Yeah.
Questions?
I got just one curiosity.
Yeah.
I haven't heard anybody talk about drugs, this type of occupational therapy.
As far as substance use disorders, yeah, there was actually quite a large body of academic research in that area that's current. And I have worked with people on that, thinking about really when you're trying to treat substance use disorder, you're trying to change people's habits and routines in their life. And that is really, I took a 6-credit graduate course on habits and routines. So how do you rearrange your life? How do you change, things? How do you set up your house differently so you don't fall into old habits? Those sorts of things.
Brian?
Well, on that note, because I was trying to think how to ask you more questions to get you to talk in detail about the work.
Yeah.
What are some ways that occupational therapists might support a person who has co-occurring disorders or substance use disorder in meeting the needs that they're trying to address or meet through their use, which often it has to do with pain and trauma? Like, can you give some examples? Like, let's say, for example, a person came to you and they're trying to start their path of recovery, and as part of that, they were referred to you to look at their life and kind of do an assessment. Like, what would that look like? What does an assessment look like with OTs, and what might a treatment plan look like?
So I'll start with a caveat that this is not my area of expertise. But if I was working at outpatient clinic and I had that referral, I would not say no. So I would look at sort of what are your current strengths and what are current things that you're struggling with, and how do we build on the strengths that you have to overcome those barriers. I also typically would do a real basic sensory evaluation. Because, there is really a lot of evidence that through trauma, right, we revert to our limbic system, so a lower level of neurological functioning in times of stress. And when we're in that state, our fight or flight state, we can't reason. So you have to look at other strategies to sort of self-soothe or, calm yourself down to then have a higher level of cognitive functioning. So it's sort of, how do you, I think PT that I work with, she's always like, you have the greatest Jedi mind tricks. And it's not Jedi mind tricks. It's knowing how does your neurology work and how do you use that to support yourself in the best way possible. And then how do you get to a place where you're stabilized? And then how do you build skills on top of that? In the same realm, I think it's not that dissimilar from the discussion that's happening quite frequently now around our aging mental health population. So we have people who have had schizophrenia or bipolar lifelong now that have been managed by by the DAs, who now are having neurodegenerative changes. And there's a lot of discussion about should this person be managed medically or should this person be managed from a mental health lens? And as an OT, I'm sitting at the table thinking, this is all happening in the brain. It's the same organ. We don't have a cardiologist for the atrial valve and a cardiologist for the ventricle valve. We have a cardiologist. And so having a foot in both worlds, a lot of times I'm the one that's able to sort of translate to say, yes, I know you think this person's medical stuff is out of control, but it's actually their anxiety disorder that they're not able to manage their medications right now. And so how can we better manage anxiety so that they can better participate in their routines of life so they stop going to the emergency room every 2 days?
That was very helpful.
Yeah.
Thank you. We'll have one more question and then we'll move on to Thomas. Art?
Yeah, you just said to Brian, when he asked the question, that wasn't your area of expertise. So with that said, then occupational therapists are not all know everything about everything. You're divvied up in, or you have an area of expertise. And so people are referred to you as opposed to someone else who might have. Is that how it works?
Yeah, it's not a specialty certification. So I've not actually had a lot of experience working with substance use. Okay. So that's an area that if I had a patient, I would go do a ton of research. I have all of the skills, but how do I organize what I do for intervention?
Okay. So you would treat the person, you wouldn't say, John Smith has more expertise there, I'll refer you to him.
I might. So if someone came in with a really severe hand injury, we do have a certified hand therapy, people that are certified hand therapists, right? The anatomy in the hand is very intricate and it is very particular and very protocol based. And you're going to get your best functional outcomes from a hand therapist.
Okay.
Or I don't typically treat children, so that's someone I would refer to Hannah, but I am certainly able to. If our national organization really outlines, if you want to change practice areas, they have outlined mentorship that you can, both the mentor and the mentee can get continuing education through, self-study and support of someone who has practice area expertise.
Would that have any impact on the compact?
No.
None of this does.
No, but it's important to understand how, what they do and how this will help. So thank you very much for your time.
Yeah, thank you.
Are we taking a break or not?
No, we're going to do 2 more and then we're going to be done for the day. How's that?
I'm gonna grab water.
Go for it.
Should I jump on Zoom or?
Yep.
Okay. I'll be quick.
Come back.
I'll be quick. I just don't want to miss anyone.
Thomas, are you there?
Oh,
I had stepped away
I
for a moment.
am.
Hi, thank you for
Hi, folks.
waiting. How are you?
Hi, I'm well, thank you.
Great, if you can, sorry, just lost my train of thought. Introduce yourself for the record and then give your testimony, that would be great.
My name is Thomas Hardigan. I'm an occupational therapist at Rutland Regional Medical Center. I've been here for the better part of 30 years. Hello, Representative Peterson.
Hey, how we doing? Good to see you.
My testimony is more around having been a hiring manager and a director of the therapy services here at the hospital. And the way that I see the compact being beneficial is around access to clinicians, which we often struggle with in the state. There's a wonderful small population of occupational therapy practitioners in the state. But sometimes we're hurting in terms of recruitment. And I think that the compact makes that recruitment a little bit easier. And the reason that it makes it a little easier is because for the folks that practice in those states that are connected to the compact, if they want to practice in another state, it makes it easier or more portable for them to move into that next state of practice, thus making the hiring process easier for us when we're trying to bring in new clinicians. And I'll give a little bit of an example right now. Even though I'm not the hiring manager, we have a position open right now for a specialty position, which is a lymphedema therapist, and that can be either a physical or an occupational therapist. Thus far, we've had nobody reach out to inquire of that position, as far as I understand. And I believe that if you had that portability of access to go across state lines, we might get people that would be interested where they didn't have to go through a somewhat tedious, arduous, and sometimes expensive process of regaining license or gaining licensure in another state. And I especially think that, you know, being based here in Rutland, we're a New York State border area. It's not unlikely or untypical to have a clinician from the other side of the border come and want to practice here. It would make it easier to make that transition. And as Emil said, I think it would shorten that time frame from weeks and weeks to maybe only a couple of weeks, and make it easier to bring somebody on board. So, I mean, that's the bulk of my perspective about it. The recruitment and hiring process. I think the other things that are important about the compact is it makes it easier to share information, both in the positive and the pejorative for a clinician who might try to practice in another state, because it makes the sharing of that information for the licensing boards easier to access and less easy to potentially hide what you might not want to become evident in another state where you're trying to become a practitioner.
That was very helpful. It was good to hear from a ex-hiring manager to see how what the impacts are. Does anyone have any questions for Thomas? You're second to last of several witnesses, so a lot of our questions have been answered.
Sure. If I might just add on briefly to Mr. Peterson's question about the specialty and whether you might defer to somebody else. So I do have a specialty. I am one of the clinicians here who specializes in lymphedema. It was a certification I attained 23 years ago as an addition to being an occupational therapy generalist. And the benefits of both sides of that, when you come out of school, in most instances, you're a generalist. And in my 30 years here at the hospital, I've worked in the acute rehab unit that we used to have. I've worked on the psychiatric services unit. I've worked in outpatient doing hand therapy and neurological treatment, and I work in acute care. So having that whole broad perspective allows us the ability to kind of be flexible across a service area or an employer, for instance, here at the hospital or the VNA services, those kind of things. And then that specialty thing allows me to focus on one particular area of practice that where people wouldn't be able to access otherwise. So just an added piece.
Very helpful. That'll help our, yeah.
Oh, absolutely.
Great. All right,
Any other
thank you.
questions?
Thank you. I think we are good. We appreciate your
Appreciate
time.
you.
Thank
Thanks so
you.
much.
Thank you.
See you.
Ella DuPont, are you there?
I am. Hello.
Hi, thanks for hanging on the line with us.
Of course.
If you can introduce yourself for the record, and then I know you've provided written testimony. I think what would be great is if we could hear some of the personal stories you have in here. Since we've had several people talk about the benefits of, or what the compact is and what occupational therapists do. That'd be great.
Absolutely. No problem. So hi, I am Ella DuPont. I'm an occupational therapist of 22 years. I've worked in every area of practice that an OT can work in, from peds to adults, from home health, hospitals, acute care, outpatient, mental health. So I do have kind of that wide swath of experience that Thomas was referring to. I have specialty certifications in home modifications and aging in place. So I'm also a specialist and a generalist. I am the Vermont delegate to the American Occupational Therapy Association Representative Assembly. So it's kind of like our policy-making body for the American Occupational Therapy Association. So I'm here wearing that hat. I'm also a clinical occupational therapist for Beata Home Health. So I have that hat on. I am an instructor at the University of Vermont OTD program. So I'm wearing that hat today. And I own a private practice that contracts with AgeWell to provide home modification and motivational interviewing services for people in their homes in a non-medical model. So I'm wearing a lot of hats here. So I'm going to speak to some of them and skip some of the things that you probably already heard 4 times.
Great, thank you.
So I'll start with my personal experiences coming to the state of Vermont. I was one of those travel healthcare professionals that was supposed to come for 3 months. So I'm clearly still here after 18 years. So I failed at being a traveler.
We appreciate that.
So yeah, well, I'm really, really happy to have stayed here. I've had a great set of experiences, but coming here was really hard, and not to be a dead horse, but working with OPR was very hard because I had 4 other state licenses as a traveler. And so the documentation required and the fees for all the documents and things getting lost in the mail, because we're talking 2001, where there was a little more kind of the electronic record that we can now access. It took 4 months for me to be able to work here. The facility that I was working at, eventually, by the time I got here, really only needed me for about 6 weeks, but they kept me on because I ended up staying in Vermont and they hired me as a full-time employee. But that 4-month time frame, I feel the compact would have really shortened. And I could have been here sooner and started seeing patients sooner because there was a real need in this facility. They ended up trying to hire 3 travelers just because we were all kind of fighting to get here. So I feel like the compact can really help people get care more expediently when there are holes in the system. As an ex-hiring manager, I can echo Thomas's comments. I have worked in management up until this year. I'd been in management in skilled nursing facilities and in home health care for 15 years. And I was responsible for hiring. And I can tell you that just to kind of skip ahead, at one point at the home health agency where I worked, it took me 4 years to fill an open occupational therapy position. There are just not people that wanted to work rurally in that environment. And so I was really, relying on travel therapy staff to kind of help fill some of those holes. And it was really challenging. They had similar circumstances with OPR that I had, where getting a license in the state was really hard. And so it really did limit some of the access to care because we just didn't have the staff to do it. So I feel like that's a relevant point because I feel like the compact would really help with that access to healthcare professionals in some of these really rural settings that we have.
Definitely.
So when I was in the skilled nursing facility, I was really relying on travel healthcare professionals. I will say that probably for the 4 years that I managed at a skilled nursing facility, I was fully staffed for 6 months in occupational therapy. Because there's just not staff in rural areas. And so I was really relying on travel staffing and similar issues around waiting months to get people to start because of issues around having multiple licenses. And so what happened is I would be working as a manager and then I'd put on my OT hat and work an 8-hour day to treat patients. And so 12 hours later, I was exhausted and then I would do it again for 6 days a week. And so I will tell you that very much contributed to my burnout as a manager. And I feel like having an easier way to get staff in when you need them would really be one of the biggest benefits of the compact. I know that travelers get a bad rap because they're expensive, but sometimes they're just what you have to do as a healthcare manager. And so if we can make that process a little bit easier, it would certainly be beneficial.
Great.
On the point of view of, I'm sorry.
Go ahead, keep going.
Yeah, I just wanted to talk about, I feel like the contract could facilitate some professional development. You know, an example is that there is an open specialty practice area certified hand therapist position that's been open at CVPH for, I would say, years now. There aren't any open positions in Vermont in some of the certified hand therapy practices, specifically at UVM, but I feel like people having the opportunity to go back and forth, perhaps work per diem, get some experience, and then be able to bring that back to the state is another benefit that people don't always consider of the compact. You know, there's an opportunity for the people that live on, you know, the borders of like New Hampshire, down in that corner where there's New York, Massachusetts, and Vermont. There's an opportunity for staff sharing that gets missed because people have to acquire 3 licenses when they work in that corner if they want to work in buildings that are 5 minutes apart. So I feel like there's definitely a benefit there to consider when considering the OT compact.
Great.
So I can stop there because you've heard a lot about the OT compact and just see if you have any questions for me.
Yeah, thank you, Ella. That was very helpful. Does anyone have any questions?
Just ask, Mayor. Thank you, Ella. I appreciate that. I was just thinking about your experience with OPR. Did you say that was 2001?
When did I come to Vermont? 2005.
Okay, so that experience in 2005. Thank you.
Yep.
Great. I think we are good. Thank you very much, Ella, for joining and sending your written testimony. Everyone is reading it, so we appreciate it.
Sure.
And have a great day.
You too.
So that's the testimony that I was planning to have for the OT. Any thoughts? Do we need to hear anything else? Are there concerns? Yep.
Curious, I've been listening. This has been super helpful, but I've been listening for like who doesn't or wouldn't want this.
Doesn't what?
Wouldn't want the compact.
Like who would oppose it?
Yes.
Yeah, like on that note, like I am curious to learn more about why states like New York or California don't want it. My understanding is it has to do with them feeling like they're losing some control. So I mean, I would vote this out now, but if we were going to look for anything else, it might be to try to find any opponent and give them a chance to make their case against it before we vote it out, just so we did due diligence. Like,
Can I hold on? Art had his hand up first. Sorry.
Well, on that note, what I was thinking would be helpful to have, and as far as I know now, I generally support it, but I'd like to see, and Alyssa brought it up to start, a breakdown of the licenses, what they cost, and just kind of a comparison cost-wise. And I know
Comparison to what?
Of what it's going to cost somebody, say in New Hampshire, to work here, or somebody here to work in New Hampshire. What are the costs and things you have to go through, the hoops you have to jump through to do that, as compared with the cost of just buying the New Hampshire license? I'd like to see Just, it'd be helpful to know it. That's all I'm saying. I don't,
So what states, I mean, because we're not going to do all the states, so.
no,
so
just,
you wanna
let's go to, let's say New Hampshire.
Okay, so you want to understand what it would cost for someone who's a provider in Vermont to become licensed in New Hampshire.
Licensed today in New Hampshire versus what it will cost with the compact.
So I don't think we can really answer the question with the compact because we don't do fees in here, right? They do it
Right.
across the hall, and none of that's been set yet.
Okay, but okay, then just what you have to do without the costs
Okay,
to be part of the compact.
okay,
Just as a visual comparison to know.
okay.
And will these be the same for somebody from New Hampshire coming here?
Wait,
you
I
couldn't-
had my hand up.
Well, hold on.
I'm sorry.
It's okay. It's
Well, I'm
a
responding to the-
continuation.
Yeah,
so-
I mean, that's my response. Okay, go ahead.
So what's the?
And vice versa,
Yeah.
is what you're asking. Okay. Leslie?
Well, I just think there are a couple of things. So if you're comparing, looking at the compact, you get 28 states. So you have to compare Vermont to what it would cost to get 28 states,
Oh, I understand.
not just New Hampshire. I mean,
Well, I'm just using New Hampshire because the chance of somebody going to Colorado and doing the work.
no, but they might do telemedicine. The point though is if you do the compact, you get 28 states in one fell swoop. So you don't have to pay any more than that.
But
So
you still have to pay to that state you're not part of.
you pay through you pay
Compact
compact. Just
You
the
pay the compact, but
That's
that-
all.
But you, from what I've heard, you pay to be in the compact, plus you pay something to that state.
I don't think.
Member states can charge a fee.
Yes.
Yes.
Well, I think one.
So you do have that fee
Yes.
from that state.
Right.
That's.
I would feel very uncomfortable, which I wanted to respond to Brian, is comparing Vermont of 620,000 people to New York with 40 million people, or California with 40, whatever million people they have. It's really the apples and like pomegranates. We just are not them. And we are so small that to limit ourselves in access to professionals, to me, seems really not thoughtful about our healthcare access. So I just want to be careful. I mean, we haven't done this kind of conversation. I think maybe that's why I'm a little frustrated when we did the last compact. So I think that it would seem simpler, and maybe I'm misremembering it, but it felt
I
like.
think we had some conversations
Yeah,
like
maybe.
this.
All I was saying is that I would vote it out right now.
Yeah.
I would.
So
So
would
all I'm
I.
saying is if
And
there's
so,
anything
yeah, you
remaining,
too,
it would be
right?
hearing what is the opposition, and the only opposition I have heard to compacts came up when I was looking into the social work one, which is that these bigger states are resistant. That is precisely for why you said we shouldn't compare us. We might hear that and be like, yeah, that's why we need it. The reason they don't want it is why we need it.
That's right.
So I think giving a moment to understand that is just due diligence, but I don't want to slow us down either.
Okay, so I'm going to comment on
Yeah.
that. Daisy?
I totally agree with Leslie and Brian. Like, I'm ready to vote it out. I think, to Art's question, which is a good one, of like, doing sort of a cost comparison in terms of, what is this cost a provider who wants to practice in a neighboring state? Like, is it going to help the provider? I also think it helps to look at the bigger picture. Is it going to help our constituents who actually need the care?
Right.
And the answer is yes, right? Because they're going to have more access. So this is, I think, helping us to achieve more greater good for the people who really need the care.
Yeah.
And if you think about it from an economic point, which, Brian was mentioning like that, or maybe it was you mentioning the cost comparison with other compacts, like, yeah, there's a job, potential job leak or whatever. But then again, we're getting more people well by improving access, therefore getting more people back into the job market too. So I'm totally in support.
Okay. 1 second.
I just wanted to respond to Brian and like cost, and you know what? It covers all the compacts we do.
Yeah.
It's, so first of all, when you talk about a state like California or New York, I would suspect, and I'm just making an assumption here, that probably because they have very robust university systems that train and have these programs, also that they have large medical communities that support these, that they would probably fear losing what they have.
Yeah.
Because I would suspect they probably don't have shortages like a state of Vermont. Namely because number one, up until recently, we don't have any universities in the state that actually train for occupational therapy. So I would think that they would be trying to retain their own people for that. The only other thing, and it always comes out, and it's the Mari, to Mari's point, and there's no stopping this train. I'm not saying that we're going to stop this train, but every time we talk about one of these compacts, we're almost, if we could go back 20 years, we're almost creating the problem of the traveling nurse, traveling this. And every time we expand one of these contracts, we're just opening up. And this is on a national level. It's not just Vermont. There's nothing we can do to stop it at this point. But yeah, we're making things easier for people to be licensed in multiple states so that they can just flip around from state to state, which means travelers. And they'll come to us in 10 years and talk about how our budget needs to go up because occupational therapists are making 4 times what an in-state occupational therapist is because they're all travelers.
Right, and so that's a separate, hold on, that's a separate and distinct issue we have. That is not just about this, it's about everything in our healthcare industry. Yeah. Alan?
Our job is whether we support the compact or not.
Yes.
Our job isn't the fees.
Correct.
Every person that wants to participate, but every one of these people that participates, they have got to make the choice whether they want to be involved in it or not.
Yep, exactly.
It's either going to be interested, they're not going to participate.
We're just giving them a tool.
Okay, that's right.
We are giving them a tool. They can choose. So if I'm an occupational therapist and Alyssa's an occupational therapist, and this becomes reality, I may choose to be part of a compact state. She may choose to not, and or do a full license in another state as well as her home state. So yes, this is a tool we are providing to people in the profession to determine how they want to operate.
To your point, Alyssa, about travelers, I would also point out that the demographic subset of people who have the logistical capacity to travel is pretty small. Most people who do traveling professions don't have small children, don't have spouses or partners who are well established in the community with a job. So it is an issue for sure, but it's a relatively small one because there's not many of us that can do this.
And hopefully those travelers could come to Vermont on a compact and then choose to stay.
Get established.
Right, which sounds like some of our folks did.
Yeah.
Right.
Yeah, that was the thing, leads to the point I wanted to make, which is that I think the first decision is how do we increase access? But then the second thing we need to look at, separate from this bill, is how do we create a healthcare system in Vermont that is enviable, that people want to work in, that retains people, that, that functions well, and that's a whole other bill. But I think we need to do that. And that this is just one tool that increases access. That's how I see it. Compacts are just one simple way. I will say, it's been very hard to try to get licenses in other states, and it's been a huge barrier for me. I know that this is not my license bill, but it's the same issue. And so, we want to reduce those barriers to access, and then we need to look at how do we take care of workers better.
Yeah.
So
I will work to try and get some information on the costs today of doing this. What I will say is I'm not going to try and drum up people who don't support it. So part of it being on the agenda, why we're not voting it out today, is that it's on the agenda. We hear the testimony, we put it on for a possible vote in the future, probably next week. And if people are opposed to this, they need to come forward, right?
Because it's out there.
Because it's
Yeah.
out there. So that is.
Let it be known.
Let it be
to the
known.
world.
We're waiting to hear from you if you oppose this.
Speak now or forever hold
Right.
your, what do they say when you're getting married?
That.
Yeah.
Forever hold your peace.
Exactly. Okay, any other comments on this?
I have a question about OPR, but it's not policy.
Okay, so we're gonna hold off on that.
Yeah.
Okay, so we're done for today. We're back. So tomorrow, we have the floor, could potentially be long, we're not sure. I did put us down for 15 minutes after the floor, just in case we have time. We may not. And then we have the governor's state of the state at 2. So we won't be meeting in the afternoon at all. So potentially we won't be in committee at all tomorrow, but look for 15 minutes after the floor if we get done at a decent hour. My other question is, and I have this written down somewhere, but I don't know where it is. Who on the committee is the education committee liaison? Who?
Not,
Is
no,
anyone?
Art was pointing at me because the page is delivered.
Or is there? No, that's okay. I thought you were pointing at Brian and I didn't think it was Brian.
That would make sense. It would make sense if it were Bob.
I was not the education person.
It might have been
I
Melanie.
don't
Might
know
have been
what.
Melanie.
Mel used to be a principal.
Yeah, so it might have been
Mel was a
Melanie.
school principal. Yeah, so it might have been Mel.
Who is remember everyone's a liaison for another committee?
You're looking for education.
I was looking for education. Okay, so can we have one conversation? So since Melanie's not here, I'm looking for a volunteer. The education committee on Friday afternoon is having VHIN, which is the Vermont Education Health, whatever. So they're the entity that provides healthcare to the teachers. And education committee is having them in to talk about the increases in healthcare this year.
The premiums.
The premium.
Oh.
I would really like someone to sit in. Brian is going, Bobby is going to sit in. Okay, all right. Bobby raised his hand first, so thank you, Bobby.
I would have done it if you couldn't, but you should do it. It's
So
really out of control.
we'll make sure Bobby gives us an update afterwards. I apologize, we had talked about doing it as a joint testimony, and then I planned testimony for Friday afternoon, and we didn't connect, so.
That'd be something I'd love to hear.
So depending on what Bobby tells us, it can definitely be something we have in here. It is not our jurisdiction, but in a way it is our jurisdiction, so it's, it would be good to understand.
Constituents will make it a new jurisdiction.
Yeah, well, it's really education's jurisdiction, when it comes to our world here.
And there's always YouTube.
And there's always YouTube. Good point. Thank you for that. I always forget there's always YouTube. So we'll do social work compact on Friday. And then I will put this and potentially that one, we'll see how Friday goes, up for a possible vote next week. And I think that was it. Sorry.
Actually,
we are still live.
Not related to policy, so I'll wait till.
Okay, yeah, we'll wait till we're off. Anything policy related?
Yeah, I'm just looking at the agenda for Friday since we're not going to be together. So it looks like after the floor, we're going to be in room 270.
Oh, right, yes, thank you, I forgot about that. So over the summer, and you two were at the meetings, right?
Healthcare costing, which,
No, at the.
Corrections.
The corrections.
Justice involved.
Justice involved. So we are doing a joint testimony with House Corrections and Institutions to hear about who provides healthcare in our prison system for justice involved people. So it's WellPath is the contract we have. There are some concerns. There was testimony this summer in Justice Oversight, and they recommended that Corrections and House Healthcare look at this and determine what, if anything, needs to happen. So we will be having that Friday after the floor with House Corrections over in the pavilion in room 270, I think.
That's right.
Okay.
That's what's in the agenda.
And then we'll have potentially a fast lunch. I apologize for that. And then the social work compact. And then we'll have a debriefing as a committee after we hear the testimony Friday morning and determine a path forward on what we might need to do.
Is there a report from the Justice Oversight that we could review?
I don't think there is a report. I think, but they had testimony this summer. Yeah, it's just a memo.
Okay.
They had testimony this summer, but this will help, this hearing Friday will basically help us understand what the issues are. And then we can figure out a path forward. Thank you for that, Leslie. I forgot about that. Okay, good first day. Thank you, everyone. We can go off live.